Barry Eiden is an honors graduate of SUNY Optometry. He completed a residency in ocular disease at the Westside VA in Chicago. He's president and medical director of North Suburban Vision Consultants. He's served as an assistant clinical professor and chief of primary eye care services at SUNY Optometry. Barry is a fellow of the American Academy of Optometry and past chair of the contact lens and cornea section of the AOA. He's president and medical director of Keratoconus Specialists of Illinois and president and founder of the International Keratoconus Academy of Eye Care Professionals. As a research consultant for contact lens manufacturers, Dr. Eiden is considered both an authority and an innovator in the area of contacts. He is co-founder and president of EyeVis, the Eye and Vision Research Institute. Dr. Eiden was an investigator on the CLEK, Collaborative Longitudinal Evaluation of Keratoconus study, as well as many other clinical investigations and studies in the eye care field. In 2019, he was awarded the American Academy of Optometry's prestigious Founders Award. He is a well-known lecturer both nationally and internationally, has done interviews with television stations and networks, major newspaper and magazines, and has been published in many scientific journals. He also serves as associate editor, Cornea and Anterior Segment for odiesonfacebook.com, and is, in my opinion, all-around great guy. So welcome, Barry.
Thank you, Alan. It's great to be here. After listening to that introduction, it sounds like I should be ready to retire. It's enough.
I know, doesn't it? Did you put the check in the mail?
Absolutely. I'll give you an extra actually coming in too, a little bit of a tip.
So happy to have you here today, Barry. I wanted to have one of the leading keratoconus experts on the show. I want to start today with some things that I learned about you. So one interview I read said you chose optometry because of an eye exam you had and you thought it was cool. But the real reason we all know is because your last name being Eiden, like Eiden.
There's no doubt that both of those are actually true. Coming from a dad who worked in the garment district in New York all his life and ended up developing a company in the garment district, Dad said to me very early on in my life, there's no way you're going into this business. He didn't give me a summer job. He wouldn't let me come in. He just said, this is not for you. You've got to be what? A doctor, right? So when I was thinking about where to direct myself in the medical field in undergraduate, I visited an optometrist and I went into his office, and what was the first thing I saw? All the instruments. This guy was very tech savvy back then. And I said, this is cool. This stuff I like. And he invited me to come to, he had study groups with a few local ODs, and I went to some of those study groups, and I really enjoyed kind of the philosophy of optometry. That's where I learned about it. But until I went to optometry school, I had 20/20 acuity, and my parents never took me for an eye exam. So it wasn't until optometry school that I actually had my first eye exam.
It reminds me of a joke of an immigrant family in which you're expected to pick whatever career you want as long as it's a doctor, lawyer, or engineer. If, for instance, you want to be a musician, then your parents would say, great, just make sure you're a doctor, a lawyer, or an engineer.
Exactly. You can sing all you want. And what was funny, getting back to Dad, was the reason why I even learned about optometry was where his factory was in Manhattan. He went to lunch with an optometrist every day who had an office near his factory. Of course, he called him Doc. He would go to lunch with Doc every day. And he says, that is a good profession. It's a nice, clean profession, he said. So he encouraged me. The name, interestingly enough, Eiden, Eiden, obviously not that bright. I never put two and two together. But when we got our first car, my wife said, you have to get a vanity plate. And it's obviously what it's going to be. It's going to be Eyeiden. And since we had two cars, she said, since I came up with it, I'm Eiden 1 and you're Eiden 2. And that's how it's been ever since.
Awesome. That's awesome. Now, you talk about your dad, and he's quite an entrepreneur, and you are too. And so I guess entrepreneurship runs in your blood. You have two practices, a research company, you consult and lecture, you do it all. You've really merged your talent for entrepreneurship with your profession. What advice would you give to young ODs with similar aspirations?
Wow, that is a really great question. And I'm asked this all the time. In fact, last night, I was just on a call with one of my former interns who was making a business decision about going into a startup practice. And so you're absolutely right. I think about this all the time. I think with each passing generation, the challenges are different and greater. I remember my professors teaching me practice management, talking about how they opened cold and they sat in their office for the first year or two reading the paper and drinking coffee. And I was saying to myself, I can't afford to do that. I have school loans. They never had school loans. Now the loans are much, much greater. I think it takes that much more background research and doing due diligence to figure out what is the best path. For me, I was very lucky. When I went into private practice, with a gentleman who was very altruistic. In fact, he brought me into the practice. He was retiring in a little under 2 years. It was all the plan for me to take over. And the first year when nobody wanted to see me because I was an unknown quantity, basically he knew that my background in ocular disease was very strong and his wasn't. He was not from that generation of optometry. So what he did at the beginning until patients would see me is that he would do the introduction, he would refract the patient, and when it came time for eye health assessment, he said, I'm going to bring in my associate. And I would come in and I'll do slit lamp and I dilate them and pressures and fundus exam and so on and so forth. I got to meet almost every patient in the practice. So when he retired, it was a very smooth transition. Obviously, looking back, that was a major financial commitment he made in me. He was paying me a salary. And in essence, for the first almost year, I didn't generate very much of anything. That's unbelievable and maybe not that common these days. But boy, if a young person could ever get a situation like that, that'd be fabulous. Well, I hope that more of the senior ODs out there are realizing that. Maybe we have to get that message across. In today's day and age, especially this year with COVID hitting practices pretty darn hard, making that kind of financial decision maybe is even harder than it was before. But you're right, in the long term, it is to the advantage. It increases the value of the practice. So maybe, the doctor might be taking a little hit at the beginning, but the value of the sale of the practice is greater when the new doctor is integrated better.
Two practice owners in our age range could talk practice management all day long, but you're the cornea guy. So if you don't mind, let's move over to talking cornea. I have a lot of questions because I haven't really kept up with corneal cross-linking, but there's standard epi-off and accelerated now. And a study in 2018 showed that epi-off is better at reducing maximum keratometry than accelerated, but accelerated doesn't reduce central corneal thickness and endothelial cell density as much. Now, 3 years later, is there any information on which method might be more preferential?
So I think we should start off by saying right now, today, there's only one FDA approved method for corneal cross-linking. That is I guess it was former Avedro, now Glaukos iLink is the term that's now being used. It's an epi-off procedure in the standard Dresden protocol, the original method that was developed out of the group out of Dresden, Germany. Epi-off, applying the UV light of the specific wavelength for a specific period of time. That is the only FDA-approved method. And as such, it is also the only approved method that is being reimbursed under medical health insurance. And many, many more insurance companies, by the way, are covering it. Obviously, cost becomes a factor for a lot of these people. However, of course, technology keeps moving forward. So other methods of cross-linking that you mentioned, accelerated cross-linking, even more importantly, epi-on cross-linking, have gone through a variety of clinical studies. And in fact, Glaukos has their epi-on method that they've already accumulated their data. And I believe that the study is closed, but they're analyzing the data. So I'm encouraged that we will see changes in cross-linking to make it more effective, but even more importantly, safer for the patient and more acceptable. We all remember from the early days of refractive surgery, and Ellen, as well as anybody, the first days of PRK, well, it wasn't the most pleasant for patients, right? You would talk about doing this procedure to rid them of corrective eyewear, and they would come in the next day miserably uncomfortable, slow recuperation of vision, ultimately doing well in the vast majority of cases. Then LASIK was developed, and I remember being in, because I was running a couple of refractive surgery centers a number of years ago, and being in the clinic and doing the one-day post-ops, and we were doing both PRK and LASIK, and you'd see the PRK patients come in sitting there like this, and the LASIK patients there like this. There is an analogy between epi-on and epi-off in that regard. We get, it's less painful, it's quicker recuperation of vision. I think ultimately it's going to result, if the studies come out the way we think they will, in a equally effective method that's just way more patient friendly. So we're going to see lots of things like that. And then there's the use of cross-linking for other things, even targeted cross-linking to induce changes in corneal shape and curvature. So everybody should realize that when you're suggesting corneal cross-linking for a keratoconus patient, it is to stop progression of disease. They'll always talk about, oh, well, you get flattening of the cornea, maybe reduction in severity of disease, but it's not as, the current method isn't very, very predictable. So we never promise patients that. What we're telling them in a high level of confidence, in the upper 90s%, that the progression of the disease will halt from cross-linking. That is the purpose of cross-linking.
Yeah, they were investigating it for a lot of things. There was an investigation on enhancing stabilizing LASIK results if someone continues myopic creep after LASIK. What does the name Damian Gatnell and the phrase no rub, no cone mean to you?
So I would say to you that that's the whole discussion of eye rubbing and keratoconus, and which came first, the chicken or the egg. So there are those out there that think that eye rubbing causes keratoconus, and there's a whole nother, maybe even a larger group that feels that eye rubbing exacerbates keratoconus. I'm in that second group. I think keratoconus is a disease that's determined by your genetics, but environment can induce progression and increase severity. So I think the term epigenetics may apply to this, where, yes, we have a genetic predisposition that can be influenced by environmental factors. Kind of like myopia, right?
Yeah, similar. Nothing happens without genetics playing a role. If you're prone and you exacerbate it, of course, it makes total sense.
Exactly. That's the camp that I'm in.
Now, let's talk about your baby, the International Keratoconus Academy. The mission I read on the website was it's an organization established to promote ongoing professional education and scientific development in the area of keratoconus and other forms of corneal ectasia. Now, I see you have some real power players that you brought together in this organization. Start by telling our viewers a short overview of the organization and specifically about the seminal research that you're doing on pediatric prevalence, where I think you have something crazy like 3,000 school-age subjects.
So let me start by saying that the organization was founded about 6 years ago. A group of us were just sitting around and we talked keratoconus because we're nerds about that. And we realized, and everybody's sharing the concept, that there's so much misinformation out there. And when we see patients in clinic, and I know you have seen them many, many times in your career, they come into the office and you just shake your head about mismanagement. So in some practices, patients will go in with keratoconus and they're like pushed right into corneal transplants. You'll go into other practices and they'll be fitting contact lenses until their corneas are scarred down to the nth degree. And so there's this siloing of treatment. And we believe that you have to approach it as a comprehensive management. And that's kind of was the seedling of IKA. And we said, let's see if we can form an organization with all of the eye care groups, whether it's ODs, MDs, and other affiliated eye care specialists and interests, and try to push forward the most current knowledge and research in the field of keratoconus, both early diagnosis and management. So our mantra is to stop the progression of disease before it influences negatively vision. And that's really what it's about. And we were able to get, as you said, a powerhouse of all eye care professionals involved in this. And it's really starting to take off. We have, as you know, our website, we have a social media page, which you're an expert in that field. And the number of members increases virtually every day. We're getting closer and closer to the 1,000 member group. And remember, this is a disease, just one disease. It's not like saying cornea or contact lenses, it's keratoconus. And so our primary goal is education. And we do that in a number of ways. And 2021 is going to be a really big area for education. We're going to start putting on a lot of virtual educational events. We're forming initially a journal club that we may do every month, where we'll have authors from some of the most important research published out there explaining their papers in short but really concise and clinically relevant ways. But then our hope as we get out of this COVID is to go live. And we've done educational events within larger meetings, AOA, the Academy. We've done meetings at the Specialty Lens Symposium and things like that. But ultimately, we want to have our own freestanding meetings and be really able to educate. Then you mentioned our study interests. So we've completed one major study that I think will be a seminal study and may have the potential to really influence what all of us do, especially with kids in our clinical practice. And that's the pediatric prevalence study. So let me tell you quickly a little bit about that. So we were able to get a grant thankfully through Oculus, who provided a Pentacam corneal shine fluke tomographer to be placed into a pediatric clinic here in the city of Chicago that was being run by people from the Illinois College of Optometry. And what happened was there were school-age kids from kindergarten through 12th grade who were bussed in every day to this clinic to have comprehensive eye exams. Most of these kids were underprivileged, vast majority African American and Hispanic. And we could talk a little bit about that with the results. But basically, thousands of kids a year were coming in and having comprehensive eye exams. And so what we did was that we randomly selected individuals as they're going through their eye exam to just routinely run a shine fluke-based tomography using the Pentacam. And we did screen close to 3,000 individuals, over 4,000 eyes. Interestingly enough, utilizing some of the statistics to screen for keratoconus, we were seeing, this is going to be unbelievable, a 1 in 5 red flag. That doesn't mean 1 in 5 had keratoconus, but there was enough to make us suspicious of keratoconus in 1 in 5 of these individuals. Wow. Now, statistically, if you look at a lot of studies out there throughout the world, we used to think keratoconus was 1 in 2,000, but that was based on pre-corneal topography. Forget about corneal tomography. It was based on, retinoscopic and keratometric findings from a screening done in the mid to earlier 1900s. And all of the newer studies are showing a much higher prevalence of keratoconus. We believe it's definitively under 1 in 1,000. We probably believe it's closer to 1 in 5 or 600. And if you think about that, imagine kids coming through your practice, right? And thinking that 1 in 500 could have early keratoconus. And we now have a method to stop it from becoming visually significant in a safe and effective way. Oh my God. I mean, Alan, we talk about this at every one of our lectures. When you see a kid who's 12 or 13 years old in your practice, the routine standard of care is to measure their eye pressure, right? Whether it's Goldmann tonometry or air puff, whatever you use, whatever technique you use. I always ask our audiences, how many in the audience in their career have diagnosed primary, not due to injury and not due to congenital glaucoma, but how many have diagnosed primary open angle glaucoma in that age group? I know I've practiced for 30 plus years, 0. Yep. But yet I still measure their pressures. And then 1 in 500 of the ones that we see have keratoconus and we're not screening for it.
Makes sense. That's, I think the accessibility of technology has made the diagnosis more prevalent. It was always there, but we just see it more with the technology now. So we know the numbers are much greater.
100% correct. And that's the challenge. And that's kind of the gauntlet that IKA is throwing out to industry. And we believe that with the results coming out this year, we're going through statistical analysis right now, really detailed statistical analysis of these pediatric results. But the gauntlet is for industry to develop instrumentation that's accessible and affordable to primary eye care to effectively screen for early keratoconus before it affects vision. We can't depend upon slit lamp findings or distorted keratometry. To a certain degree, we can't even depend upon placido topography because most cases of abnormalities in placido topography, it's already affected the front of the cornea and most likely has affected vision. We know that it all starts on the back of the cornea with changes in corneal thickness distribution. These are measures that we can't measure with traditional instrumentation. But I believe that industry can develop appropriate instrumentation and make it affordable. That's the gauntlet we throw down. Yeah, so we are really ramping up our educational efforts. One of our executive board members, John Gillies, is really taking the lead on this, and John's going to help us get that organized. We just had a meeting virtually the other night. We're working to put together, first of all, a monthly, as I mentioned, journal club where we're going to be doing research reviews of published papers, hopefully get some of these authors to come on and do a 20, 30-minute review of their research and how it is clinically relevant. And then we'll have some of our IKA board members on to have discussion and take questions. That can go on monthly. That's one thing we're trying to put together. And then we're going to do larger CE events, initially virtually and then live. So we're really trying to ramp up the educational aspects. I want to invite anybody with any interest, which should be most all of us who in keratoconus, to join IKA. It's absolutely free. Our sponsorship from industry allows us to do this for free. So if you go to our website, if you don't mind me saying
Please.
the website, it's www.keratoconusacademy.com, keratoconusacademy.com, and you can go to the subscribe page, and there's a little code for complimentary membership. Boom, boom. When you're a member, you start getting all of our communications through our email list, our listserv, and we share ideas and thoughts, and we tell you when new presentations will be out there. And if you have cases, you want to throw it out to some of the biggest names in optometry and ophthalmology and keratoconus, you could just post a case and people will give you feedback, probably more than you want.
So tell us a little bit about EyeVis, Eye and Vision Research Institute, which is your R&D company.
Yeah, really interesting. So back, oh goodness, it's got to be close to 20 years ago. A dear friend of mine who also practices in the Chicago area, Rob Davis, and I, we've been involved in clinical studies in contact lenses, solutions, and pharmaceuticals for years and years. And we realized that there's a lot of small companies out there that want to get research done, but they don't have the the system in place. They don't have people to conduct the research. They don't have study sites. They don't have statistical analysis. And we had connections. So we just decided, let's form a company. So you got Eiden and Davis, EyeVis, forming a company where we can do research projects for generally smaller companies. We've done it for some of the larger contact lens companies that don't have the interest or ability at that time to do perhaps a smaller study that internally they don't want to do. So we've been running studies for years and years, and it's just another fun thing to do, to be honest with you.
I think it's a little bit more than fun. It's a business. Any interesting studies you can tell us about that we can look forward to learning about?
The biggest study, I think, impactfully, although there were issues with the study, was our study called the SMART study. You may be familiar, myopia dude. Yep. So you know about the SMART study. So back then, when Ortho-K was just getting approved, right, which was about 2001, there was a group in Chicago. A lot of people have been doing Ortho-K off-label for years. We got involved on the preclinicals for Paragon, so we didn't do it before that. So a group of us got together, and we kind of got together to potentially do cooperative marketing. So we would educate the public about Ortho-K. And we realized soon at this dinner that we got together that none of us could agree on a damn thing about doing cooperative marketing. So that kind of fell through the wayside. But what was agreed upon at that meeting was that for Ortho-K to ever gain traction, the only advantage of it that really would resonate is myopia stabilization. We knew it back then from clinical input, but there were no great studies. There were suggestive studies, there were pilot studies. So at that point, we put together the largest myopia management study of orthokeratology ever done before, where we had over 300 subjects doing a 3-year study, 150 in daytime wear soft lenses and another 150 in overnight Ortho-K. And we monitored them for refractive changes, biomicroscopic abnormalities, if they should occur as adverse events, and axial length elongation. And we showed in that study definitively that the Ortho-K group progressed in myopia refractively at a significantly slower rate than the daytime wear soft lens wearers. The problem was in that study in axial length, and we learned a lot. And the reason was the instrumentation. We were utilizing ultrasonic axial length elongation that was very technologically challenging, and we had 10 study sites, and the data was all over the place. So this AL data did not really support because it wasn't quality data. Today we know we use instrumentation that's much better, as you well know. Utilization of techniques that are reliable with much less noise and much less test dependent or examiner dependent. So that was probably the biggest study that was underwritten with a unrestricted research grant from Bausch & Lomb. which was phenomenal. They said at that point for outside studies, it was the largest study and most expensive study that they'd ever done. And Euclid provided the Ortho-K lenses. And one of the cool things that we learned from that was empirical fitting of Ortho-K works really well, because up to that point, most of us were doing Paragon diagnostic lens fitting. We realized that first lens off of Ks manifesting corneal diameter resulted in the low 80s% of first lens hit. And that was huge. And now they've even refined their algorithm better. And I believe they're in the upper 80s with first lens. And we're seeing that kind of success all the time.
And that's thanks to the reverse geometry lenses. You, like me, I used to fit Ortho-K with spherical lenses, and getting them to balance on the apex of the cone was a lot of hard work. I love how candid you were about the error in that study having to do with using the handheld measuring devices for axial length. That being the reason, just so the viewers know, every time you measure axial length, you or whoever is measuring it comes in at a slightly different angle with a slightly different pressure. And for that and other reasons, ultrasound, if you're really doing myopia control, it's vital to get an instrument that's fixed, like the IOL Master or Oculus's device, because axial length measurement and repeatability in axial length measurement is crucial. So
it's crucial. Well, I lecture on this as you do all the time. We've been in advisory meetings together on this over the years. And, I've always been a proponent of measuring axial length as a critical element of myopia management. I've had arguments with really well-known myopia management people, whether you need to measure axial length. And I always use the analogy of Weight Watchers. It would be like going into Weight Watchers every week and just seeing how loose your pants are, as opposed to getting on the scale. So, I have that slide actually in one of my talks. We got to measure what we care about. We care about axial length. That's what we're worried about, right? All the complications are due to the elongation of the eye. How could you not measure it? Once again, gauntlet to industry. Make it accessible and affordable. It's happening, as you know. You've seen, I think there's a Topcon topographer now that has axial length. Oculus is developing an autorefractor that has axial length called a Myopia Master. Hopefully it'll be approved soon. The Lens Star system, the IOL Master, which is what we use in our practice currently. These technologies are becoming more and more affordable, more and more accessible. And if you're going to take the dive into myopia management, what do you have to do? And Alan, you know this better than anybody. You got to make investments in your technology. We've been dedicated in our practice to technology from day one. Why? Because I thought that was what was cool about optometry. That's why I went
into
toys.
It.
So right? The great toys, big toys for big boys. And, all of my sales reps love me because it's really hard for me to resist new technology.
I'm the same way. More than one machine that's turned into a coat rack for me, just because it was sexy when I first heard about it. So we're going to head to the end of the show and wrap it up soon. And I want to move outside of clinical care and have you tell our viewers about your passions outside of optometry.
Oh, yeah. So if I had to really identify, there's a few things that I love in my life and make life worth living. Of course, number one is family. And I have, I think the greatest family, greatest kids, greatest wife. I have two kids who live out in San Francisco, and with COVID, haven't seen them for over a year. And I'm going out of my mind. And, these virtual conversations are starting to get old to me. Well, thank God, myself, all of our doctors, including my wife, who's also an OD, by the way, we're all double vaccinated. We're ready to rock and roll. And we'll be heading out there very, very soon. And I can't wait. And I just want my kids to get vaccinated so we can give really big hugs to each other. Otherwise, the other things I love playing golf. I'm really into wine, as you well know. Love to drink the wine. You're trying to help me, along with a few other friends like Tom Arnold, in appreciating the brown stuff, the brown liquor. So I've been playing around with a little Macallan 18 over there. I like to play guitar. And in terms of lifestyle, I love to travel, as you do. So I can't wait to get going again in those areas.
We'll definitely get to the bottom of the bottle next time. I found out last week that I developed an allergy to wine. It stuffs me up. I can't sleep, but I don't miss it too much because I don't have a sweet tooth. So I'm okay with that. I use that extra time and calories to drink whiskey. Now, your wife's an OD. Her name's Carol, right?
Yes, she's, at this point in her career, really become very, very part-time. She exclusively does low vision care. So it's great to have somebody at the practice doing low vision who's passionate about it. And she loves taking care of those patients.
Very rewarding. My career started out as a low vision specialist and evolved out of that. And your kids, what do they do?
So my kids, interestingly enough, are all in tech. So my two sons are in software engineering. So they're out with tech companies out in San Francisco in the Bay Area. My eldest son is with a pretty well-known company called Twilio. And my second son is with a startup, interestingly enough, in the pharmacy area. He's with a company that's doing virtual pharmacy called Alto. And then my daughter, who didn't go into, into computer engineering, she was really more of a marketing and PR person, actually got into technology through biotech. She's here, thankfully, in Chicago and working with a company that's doing genetically based directive care for physicians in the area of cancer treatment, depression, and has been doing a lot of COVID work actually over the last year. So it's everybody is all my kids are one way or another in tech, and so when they get together and work remotely, they're sitting at a table with computers out, and I look at the screens and I don't understand what's on the screens because they're into code, So.
Yeah. Glad I was never into that. You need to talk to Walt Mayo, one of those ODs who knows code too. Well, listen, Barry, sounds like a beautiful family. Thank you for taking time out of your busy day to come on the show. I want to remind our members to go look at the International Keratoconus Academy website, keratoconusacademy.com. That's a mouthful to say 10 times fast. But sign up, get the education through the podcast, and Barry and the team of docs who are top-notch. All of them bring a ton of information that's free for you, supported by industry, and really helps drive benefit to the general public and your patients as well. So go there and do that. And Barry, this has been great. I hope sometime I can have you back on.
I would love it. This has been a lot of fun on a cold Chicago day. It's great to be on with you, buddy.
It's cold here too. I'm sitting in a drafty basement doing this. My hands are in my pockets.
Soon it will be better.
All right, my friend, listen, stay in touch, and I'll see you in the summer at a conference or somewhere optometry related, and take care.
Thank you, Alan.